So we had a very, very large group of people. Sorry, I'm going to be looking around here because I have the big computer. I got my notes, all the questions I want to ask you gentlemen, and then I got the slides over here. I feel like an ESPN sports producer here.
You're the
Welcome,
maestro.
welcome, welcome, welcome to all the registrations today for our webinar. Today's topic is going to be modern peripheral neuropathy protocols with doctors Dr. Phil Straw and Dr. Lon Caleb. So this is a real treat. Um, Obviously the topic is going to be peripheral neuropathy. But first, I want to thank you for even joining us. Algemed has been doing an excellent job in regards to getting real experts and bringing them on board to teach you guys, the clinicians and doctors around the world, how to leverage transcutaneous pulse radio frequency with conditions that a lot of people struggle with. And Algemed Stimpod does make them considerably easy and easier. And we're going to be talking about that. For today, let's see if my slides will advance. Your panelists are Dr. Phil Straw and Dr. Lon Caleb. So I have some bios on you. If I could brag on you guys for a little moment here. Dr. Straw has over 14 years at the forefront of peripheral neuropathy treatment. Dr. Straw's pioneering protocols have transformed the lives of more than 20,000 patients suffering from peripheral neuropathy. His evidence-based methodologies focus on identifying and treating the root cause of neuropathy, not just masking the symptoms. For Dr. Caleb graduated from Southern, right? Southern in 1997. He's also has his diploma in neurology, and in 2022, he earned his master's in clinical neuroscience. He also has 27 years in clinical experience and currently is a consultant helping to drive efficiencies in cash-based and insurance-based practices. And so between you both, you guys have a lot of experience. And if I could ask you guys to maybe brag a little bit more, you guys have even worked together in the past, right?
Oh yeah,
Absolutely.
Yeah.
we
So
go way back. He was actually in my wedding many years
yeah,
ago.
he was in my
Wow.
wedding too.
2001.
That's incredible. So it's fine. So I know, obviously, I've known Lon for years, and Dr. Straw, you're a little newer to me, but I've heard a lot about you. Like, so your name's not new to me, but I didn't even know you guys are in each other's wedding. So I'm going to give you guys a moment to tell us about your prior experiences in regards to peripheral neuropathy and what you guys have done, because I think people need to hear that background because it was big. It was a very, very big deal and continues to be a big deal. So who wants to go
Yeah.
first? Dr. Straw, can you share with us
Yeah,
some of
it's
that?
interesting. Neuropathy kind of came on the forefront for me and actually Lon too. And back in 2010, we were doing a lot of decompression type patients, disc type etiologies, and when you see a lot of disc patients, you start realizing, hey, there's other things going on, right? Whether it's radiculopathy or flat out peripheral neuropathy, and we really didn't have any solutions for them. And so we kind of started going down the rabbit hole back in 2010, like how can we help these patients? And over time, we just got more and more confident of helping them and started learning how to reach out to them. And then ultimately, it's the first thing is to have a good system to treat these patients, but to really see a volume and to open multiple clinics like we did, you have to have a marketing system. So that was part of the education too, as well. But like you said in the intro, over 20,000 enrollments of neuropathy patients over that last 14 years, and so you get a lot of different people coming in, and it gets to be a lot of fun, and a lot of systems bore out of that as far as how to treat people and how to the management part, how to help them get enrolled so they get the care they need. But it's been a lot of fun, but it's crazy how fast 14 years goes by. And
Crazy.
it's 2025, so it's got to be up to it's like 25, it's 15 years now, man.
Wow. Well, Lon, do you have anything to
I
add there? Because I've heard the stories from
yeah,
back in the day.
yeah. So, really, literally, Phil and I, Dr. Straw and I have been really good friends for, gosh, 30 years, chiropractic school. And I actually at a time became his associate. So the thing I liked about Dr. Straw is he wasn't afraid to spend money to get me trained. So I learned all this stuff. So when he brought about the peripheral neuropathy, I was like, what? What's this all about? I didn't know anything about neuropathy or any neurology. And it actually led me to getting advanced degrees in neurology because I knew that we were coming up with some strategies that were going to maybe be controversial or be scrutinized. And I wanted the academia to be able to back it up. But when we started it, I was working our satellite office in the area where I was born and raised. That thing took off so fast. I mean, gosh, within a couple of years, I think Dr. Straw opened up 7 offices. So we were when I say we were big hitters in neuropathy, I think we were the biggest offices in the United States treating peripheral neuropathy. I mean, the numbers that we saw, and obviously getting good results in our treatments, but at the end of the day, what was the thing that was getting us busy? We were able to turn patients coming into the office into cash paying patients. And we were getting a very nice fee for every case. I became a very good closer thanks to Dr. Straw in getting me trained to do all that. So that's why I do what I do
Well,
today.
that's the thing.
But
Lon has always been a natural, he had the natural ability to build rapport,
Communicate.
help enroll patients. And so he has a gift for that. And it's definitely, he's always excelled at that. Then adding his further training in neurology, it's a great combo.
Right. Yeah. I mean, you guys were absolutely massive. I mean, just the stories are like folklore, but they're all true, right? Like you guys were
Yeah,
just,
we've you know, when you add it up, it's well over $100 million in neuropathy enrollments over that course of time.
yeah,
Probably
no,
closer to 150 million, actually.
yeah, no, I've heard about it all through and through, which is incredible. So, to those on the webinar, what you guys are hearing are people that are gifted clinically and innovative, and that's why Dr. Kalapp got his education because he wanted to be able to combat any scrutiny because that happens when you're cutting edge. That's the reality. But they're also entrepreneurs and they're excellent communicators. So when you're going to be listening to the webinar, I want you to pay attention to some of the clinical insight. But I think hopefully I can pull out of them as well some of the communication strategies that they use, because that is a big component of becoming successful in this. And you have two people that are masterful in this. But before we dive into some of the communication strategies, Dr. Kalapp, this one's on you. Let me see
sure.
here if my slide will move forward. Can you update our understanding of peripheral neuropathy? Because here's the thing: what we were taught in school may not be the best model to understand peripheral neuropathy anymore. So this is. I know you gave me some slides. I put them in there. They are next. So let me move it forward. And here you go. Can you take this away, Dr. Killip?
Yeah, go for it. All right. So basically, guys, this is what I want you to think about. There's historically been two schools of thought for the pathogenesis of diabetic, and we're talking mostly diabetic peripheral neuropathy. So basically, you have these two different schools of thought. One is like the autonomic, it's an inflammatory response, and its impact is because, high inflammation as a result of high insulin, high blood sugar. And what's interesting is in the past, we used to think, well, the blood vessel starts to die and less blood. And yes, there's definitely a deterioration process. But what happens is when that starts to degenerate, you get all these inflammatory cytokines. You get the, interleukin 6s, and which is a pro and anti-inflammatory property. And literally what happens is it's not always a decrease in blood, but sometimes because of the inflammation, it's an increase in blood. So basically what's going on. So these are the two old school thoughts. So basically peripheral neuropathy, notably from diabetes, is primarily a microvascular complication, and we all know that. Loss of blood supply leads to degradation of peripheral axon microstructure, ultimately leading to nerve death. Now, again, that's a little bit of an outdated scenario. Now let's get into another older hypothesis that diabetic peripheral neuropathy is caused by mitochondrial induced toxicity, ultimately leading to nerve death. Okay. But what they're found out in their research is that, hey, there's some new hypotheses out there. Okay. One of them is that neuropathy develops due to pathogenic assaults such as diabetes or hyperglycemia, or a viral attack, and it causes uncontrolled pain due to trauma or surgery causing nerves to become hyperexcited. So think of, instead of death, think of things becoming hyperexcited. Now, this consistent triggering of this hyperexcitability nerve is it impacts the energy of the mitochondria. So think of this, think of the mitochondria as like a battery. So the battery doesn't die, it just becomes very injured and very lackadaisical. So it's almost like we had to figure out a way, how do we get this axon? How do we get the juice in there to get this thing going? And it's like, because of this energy crisis, the nerve starts to protect itself by making the microstructural axonal nerve changes that are associated with peripheral neuropathy. Now, this is a bit like your computer going into sleep mode to conserve energy. Now, how this is like realistic to our practices today is when Dr. Straw and I were treating these patients, we were real careful not to accept every patient that came through the door. So there were some people that just didn't have neuropathy, so you get out of there. Or there are some people that you think, hey, they're too far gone and you got to kick them out. Well, nowadays it's like, no, I don't think you kick anybody out. Because remember, we're not saying that the nerve is dead, right? The nerve is not dead. It's just really damaged and its energy is severely depleted. So now we have a mechanism of basically plugging in the battery and getting some energy in that thing. Now, unfortunately, the microstructural changes will not spontaneously revert to its original state when the pathogenic assault disappears. As the nerve has adjusted to a new homeostatic state, keeping it in sleep mode, it needs an external trigger to start up again. Gee, what's that external trigger? Well, that's what we're here about. All right. Also, the reason why it's important to get and start treating these people is you don't want to develop plastic changes. Neuroplasticity is a real thing. We think of neuroplasticity as a wonderful thing when we're treating strokes, but how about the negative impact of neuroplasticity where people now have chronic pain? So this is where Algimed is on the forefront. And look, we're not only treating these people for acute scenarios, but we're helping them in their chronic situation. And we do know through the research that we will make neuroplastic changes affecting the brain as well, you guys. And that's something that I have seen clinically. So finally, a big departure with the hypothesis compared to the previous hypothesis is that the nerve never dies. I want to make that very clear because this is probably new to a lot of you. This is great news because the implication is that the nerve can go back to the original state, effectively curing neuropathy. Now, obviously, we have to be careful with the word cure, but you guys know what I'm saying. All right. So that's the big difference with it. It says, so in summary, peripheral neuropathy is an epigenetic neuroplastic response due to the mitochondria becoming overwhelmed from the persistent metabolic demand preceding neuropathy. New research has shown that microvascular complications does not necessarily precede neuropathy, suggesting that the two events might coexist without one necessarily being responsible for the other. However, they most certainly will influence one another, which we'll talk about it later. Okay. There you go, Freddy's.
Awesome. Thank you very much.
Hey,
So
I just like to underline something what you said there, which is super eye-opening, and that is the nerve never dies completely. And that's a consideration a lot of guys have out there, like when they accept a patient, like you're saying, Lon, it's like I just look back of the thousands and thousands of new patients we had and the people that we thought maybe we couldn't help.
Exactly.
But knowing this science is that if you can stimulate, wake that nerve up, even those people that you're scared to treat, and I'm sure a lot of guys online right now with us are treating neuropathy already, and people, when I talk to doctors, hundreds of doctors around the country, a lot of them are just scared that they're not going to get good enough results, and so they shy away from some of these people that could really get the help. And I'm thinking of one I'm taking a classic one too. Some people have motor weakness, right? So like foot drop, that type of thing. And quite honestly, I really shied away from that. If you have foot drop, I'm thinking that nerve's dead. We're not going to help that. But after learning about Stimpod, these guys are waking the nerve up, even with motor loss. So that's like a miracle.
Yeah.
That's like a miracle for these people because they're coming in with foot braces and things like that. And now the ability to help those people, I mean, the certainty level should just, as high as it is, it's just gotten higher for me. And I'm sure, a lot of these docs out there can relate to what I'm talking about.
So what he's
I think it's
talking
great that you
about,
I think it's great
go
that you
ahead,
brought
Fred.
up foot drop because for both diabetic peripheral neuropathy of the lower extremity and things like foot drop, you in 1 to 2 treatments, you see these patients' gaits change so obviously that it's like dramatic for everybody in the room who's watching it. Like when you take
Exactly.
somebody who has a wide base gait from peripheral neuropathy and treat them once, and they literally get up and walk around and say, "Whoa, that is like."
It's a
I just
game
got
changer, right? I mean, these people are coming in with, we're talking about neuropathy pain and that type of thing, but as far as affected gait and falls, I mean, that's the number one, top on the list for seniors losing their ability to live alone is, falls and not recovering from it. So having certainty that you can help their gait and help their balance, I mean, this is the tool that we've been waiting for.
right.
This,
No,
you guys, as a functional neurologist, now listen, I just sold my second practice, so I really don't have a brick and mortar right now. I'm doing mostly consulting, but I do have my private concierge patients. And I'm telling you right now, I have used Stimpod for the last 2 years. I'm the one that has tested it. As far as drop foot, I don't know what else you would do. This is the best thing I've ever seen for drop foot, and I've helped many people, guys. I'm not saying because I've treated 2 people and they'd have success, but what else is this for? I can go into an old folks home. You give me the people that are having balance issues. You do something called a gait protocol using the Stimpod. Fantastic. And they
Right.
pay me very well to go in there and get grandma to get to walk again, or at least make it so she's not in a wheelchair. She can walk in her walker. So that I kind of think I always have a thing with elderly since we were in the neuropathy world for so long. And, we had a lot of elderly patients. So I like to think they look at me as like a big grandson. So, but yeah, you're going to help these people with balance. It's not just helping with the peripheral neuropathy. It's about helping you guys. There's total whole body protocols with the Stimpod. That's why I'm so excited about it.
Hey, Dr. Kalapp, I have one more slide that you gave me. I'm going to put it up there. I like the analogy that you gave in regards to what TPRF, which stands for transcutaneous pulse radio frequency, does in a patient in regards to, you talked about the battery, which is like the mitochondria and the neuron and the axons, how that it's like the axon and the neurons aren't dying. The battery just resets its homeostasis at a decreased level, right? And it does
Yes.
that in an effort to survive. But then you said something very interesting. You say, "Hey, well, how do we charge up that battery?" So can you speak over this slide right here because it gets a little sciencey, but I think it'll help people.
What I don't know exactly what you're asking. I look at Stimpod as basically it's a targeted therapy that restores proper spinal excitability. So basically, you got this excited mitochondria and all this freaking out, and we're getting it to calm down. And it improves the cortical networks, which is important because, again, we don't want this thing to become plasticized. Pain that's plasticized becomes chronic pain, and we all know it becomes limbic, they become emotional, and it becomes a nightmare. So that's why I really like that I have a tool in my arsenal to treat neuropathy or any of these things with the Stimpod. Okay.
Awesome. So I enjoyed them. I enjoyed the analogy. And then before we have our conversation, and I think another thing that I took out of our conversation of us three was, and I remember it is saying that it was a good trigger. Because if the mitochondria aren't at a level to rebuild and increase function, then nothing's going to happen, right? You can put energy into the area, which there's ways to do that, but if you can't get into the mitochondria specifically at the rate that transcutaneous pulse radio frequency can, you won't get the success you want. Now, listen, we all know there's other tools out there. And we're going to talk about other tools in a moment that can get energy into the area, right? But nothing does it the way pulse radio frequency does. So, speaking of things that we've done in the past, Dr. Straw, I'll kick this back to you. I think it's useful to learn what we've done in the past to learn from it. Because I know myself as well that I've tried things, bought things, spent a lot of money in technology and gadgets and things, hoping to get me a specific outcome with a certain patient population. Sometimes it works, sometimes it doesn't. Can you give us a little history lesson in regards to what you guys have tried since I'm sure you've probably kind of done everything?
Sure, sure. It's definitely been an evolution over time, like how to get the best outcomes, right? And so when you're in practice, it's easy to stack up the modalities and throw everything at a patient trying to get them better. I mean, I've talked to some people, they'll have like 6 modalities they're throwing on a neuropathy patient and just, throwing, seeing what sticks type of thing. But over time, we realize like, what's the critical things? Like, what is the critical things to get a result? And so we've always had the base of our treatment has been based on we want to increase the circulation, we want to increase the blood flow to the area because we know good things happen, and we want to bring down inflammation. So the kind of core, the base of that is light therapy, right? And so when we've introduced light therapy to the patient, we used to only do it in the office, and and that was a foundational to bring increased blood flow, angiogenesis, and that was a foundational thing. But over time, we've like, what else do we need to get a good result? And the other foundational element, I mean, I don't want to bore you guys giving you every specific protocol, but the foundational part of it, that's the more we stuck to it over time, the better results we've got is definitely you got to handle their diet and you got to have the right supplementation so they actually have the nutrients to build up their nerves. And so by improving their diet, low inflammatory diet, by giving them the correct folates and B vitamins, these patients have everything they need to start getting better. Everything you need, I say in quotes, but we weren't getting everybody better. Again, we were dismissing patients we didn't think we can help, the people that were too far gone, the people that had muscle weakness, severe muscle weakness, we were shied away from them. So as well as that has worked, there's always room for improvement. So we always had the can I approach, constant and never ending improvement. Like, how can we get better? And so on the flip side of this, of what the doctor can provide, it's also on the patient. It's the responsibility of the patient to adapt certain things to do at home to get better. And so one of the things we found was like when we gave them light therapy to do daily at home, the results got better. When we gave them nutritional and we helped them advice and kept them accountable, they got better, right? And so over time, what we realized though, you can overdo that. And so, whether you're giving them different electronic stim devices to take home, other types of equipment, the other thing you got to remember is the patient's only going to tolerate so much to do at home. You could give them the best equipment to work at home on themselves, but you got to realize they're not going to spend 2 hours in the chair treating themselves. And so on the flip side of that, we came up with the philosophy of minimal effective dose. What's the minimal you can require of this patient to get the best result? And what's great about a device like Stimpod is it's not intensive. It doesn't take that much time. You can train the patient to do it, and they can do it in the office, or you can send them home with it, depending on their condition, their severity. But you can do things that are going to promote patient compliance. And the more you do that, the more you're going to have a long-term effect on the patient, not just the short time they're in your office, but if they have a chronic condition like diabetes, for ongoing for the rest of their life. So that's what we want to set them up for long-term success. So minimal effective dose of what's working the best now. And the thing that we're excited about right now is the Stimpod stimulation for these patients so they can get even better results, and the doctor can have clinical certainty that they can help people, what makes you more confident and helps your results in practice do better, and you'll be able to reach out with confidence that you want to help everybody you possibly can.
Well,
And
this is
what's
great
nice,
segue. So, go
what's
ahead,
nice
Lon.
about this technology too is, look, when Dr. Straw and I first started, buying the equipment, the equipment, we did a lot of frequency therapies. We used the Hockameds, we used the Synexus, all these different,
Rebuilder.
all
Yeah.
that stuff. And this is the kind of, looking back at it, this is kind of how I view it. And I say this with all humility. I like to think up until now, treatment has been external. Well, what does that mean? It means that everything that we did was to increase blood supply. It was like an indirect way to get at the nerve. And yes, you're doing E-stim and it's going to impact the nerve, but not to the way the stem pod, because basically Stimpod it's the first of its kind to actually get into the axon. This is pulse radio frequency goes inside the nerve where everything else is more external, and it's treated from an external perspective. So this is the first treatment of its kind that's going to get internal. And well, okay, we'll already have Synexus, already have these Hockameds. Yeah, but they cost what, $30,000 to $60,000. Now you can do better, and it's only $5,000 per machine. That's like revolutionary to a guy like me who does think as a consultant, who thinks about the money and all that. That's
Yeah.
why this is a game changer. Can you imagine if we had all stem pods back in the day? We probably
I
wouldn't
know.
even be
It's like,
working right now.
yeah, the thing about it is, even if you're stacked up with all this equipment, you got all these great, there's nothing wrong with the Hockamed and the Synexus. Those are great machines, but you still aren't getting everybody better. You still are getting some patients that are getting frustrated and quitting your care plan a month into it because they're not seeing results fast enough. What StimPod's going to do for you is help you get results quicker. Am I correct? I mean, right? It's going to help you get
Yes.
it quicker, and it's going to help those difficult patients. So even if you're doing other modalities, this is just going to make you look that much better for your patient.
Exactly. And
So,
understand, we're talking about the impact of the stem pod on the actual feet. But another proponent that we recognize in helping neuropathy is dealing with the vagal stimulation component of stem pod. That basically you put the stylus up in the posterior auricular area, which is a branch of the vagal nerve. And what's that going to do? Well, that's going to decrease interleukin-6. It's going to help the cytokine surgeons. You know, we all remember that from COVID. Well, that happens in neuropathy. You're getting these cytokine surges, and that's what's causing this discomfort and the pain and things to start to deteriorate. So we're able to impact it just by doing vagal stimulation as well. And you can do both.
Yeah,
That's why
there's a
there's a couple. Go ahead, Freddie's.
no, I was gonna say that. I mean, there's various ways that we could apply this technology to help these patients. But I'm gonna grab the wheel here and I'm gonna steer them into because I people are already messaging, being like, "Let me hear the. I want to hear the details. I want to go into what does a treatment look like." People are excited about this. I go, "What does it really look like?" And I guess Dr. Kalapp, I'll let you kind of take over this, or both of you guys can kind of jump in this. I think Algebra does give really good guidance here. They actually created some good visuals for us. Dr. Kalapp, I'll be your mouse here since I'm kind of steering the slides. Can you talk about what's happening here for lower limb?
Absolutely. And guys, and I'm of the school of thought, I make everything simple. Guys, this is simple. So what you're doing is you got the stem pod and it's got a little pad that you put on the opposite leg. Why do you put it on the opposite leg? I believe because you're going to stimulate reflexogenic pathways of the spinal cord. So then you put the stylus, you're going to put it on the popliteal fossa. And this is what the best part is. More is not better. I do it for 2 minutes each spot. I only do personally 2 spots per leg. So I'm going to put the ground on the right, say the right common peroneal. I'm going to put a little sticky thing there. I'm going to plug it in. And then I'm going to put the stylus on the left popliteal. I'm going to put it there for 2 minutes. Then I'm going to pick it up and you got to put a little gel on it. Okay. And then I'm going to put it over the common peroneal nerve. Okay. Right there, right where that fibular head is. And you're going to find that you're in the right area because it's going to cause tympany. It's going to cause that muscle to move. Okay. So over the
Here's
common
the other side.
peroneal.
So here's the
Yep.
here's the actually this is the tibial nerve, right? And you see it's a popliteal fossa.
Yep.
And they give these images, so you'll see the plantar and dorsiflexion. And then if you're doing the other side that Dr. Caleb's talking about, let me see if I can get this to move. Here's the lateral aspect of the knee. You'll see foot eversion. And looks like that. So here we got it all in one slides. We were talking about what are we seeing for average visits for a peripheral neuropathy program. I've talked to a bunch of the clinicians that are doing treatment with it. I gathered 8 to 12 docs, but I want to ask you, since you guys are the masters of this, does that seem about right from what I've heard?
Yeah. I'd go up to 16, 8, maybe to 16. Depends how severe they are.
Right. And then I've also, so this is me gathering from, this is me gathering from all the information out there. If I can go
So
back
this
here.
is my recommendation. You do it
Mhm.
2 minutes each nerve. Don't do more. If they can tolerate another minute, I don't really think you need to go above 3 minutes. If you do it over 3 minutes, sometimes it can really, the patients can be kind of sensitive to that.
Right.
So that
And
definitely can
and
happen.
thank you
Go
for
ahead.
mentioning it. The worse, the more severe the peripheral neuropathy is, the less you actually do the initial treatments for sure.
Yeah. Yes.
You're going
Because
to
you're going to
start
wake up these nerves.
exactly, and which can be uncomfortable for somebody that has a nerve that's reset its homeostasis to having no sensation.
Hey,
You know,
what about mentioning, guys, the fact that this, as much as it looks like it's an attended modality, you can train your patient to basically you put it in the right place and they can just sit there for the whole time and do it themselves. It's not
yeah.
like you need a staff
That's
member
I'm
hovering over
glad
them.
you reminded me. I've never personally held that stuff. I make the
Right.
patient hold the stylus themselves, and they don't mind at all because I'm busy. And I want you guys to be busy. So as a consultant, I would say just have them hold the stylus. They don't have a problem with it, and you can leave the room for a few minutes. They're not going to hurt themselves. This isn't something that's going to fry them. You're not going to see smoke or anything. No, it's very safe. And they kind of get excited because now they're part of the treatment.
And guys, let me just talking about volume. I know some of you guys are really busy out there. It's like, hey, safety is number one, right? So you never know. You got 1,000 people hooked up to a Hockham bed. Someone's going to get burned eventually. So
Yes.
that's what I like about this. There's no chance of a person harming the patient, burning their skin, anything like that.
Yeah,
Yeah.
makes it very simple. So the rest of the aspects are the technical aspects. So, pulse width, you can keep it at zero point 0.1. Your frequency, you can keep it at 2 hertz. The
Yes.
milliamperage is to set the tolerance. Should never be painful for the patient, correct, gentlemen? And
Yeah.
how you
Never.
know you're in the right place is just anatomy. And like we said before, when you're on the common peroneal, you should have that foot eversion. When you're tibial, you'll see that ankle plantar flexion and dorsiflexion. And it's literally as simple as that. You know, it's as simple as that. And like they're teaching you, you have the patient use the probe on themselves. You teach them what they're supposed to see in regards to the motor aspect, and then that's it. That's how they know they're on the right place.
Also,
Gentlemen,
when you
any other guidance for treatment? Dr. Caleb, go for it.
Well, just real quick, understand that when you're treating grandma with peripheral neuropathy and she says, "Oh, my feet are feeling better," when she gets up after every treatment, she will notice better balance. I just want that is going to be an outcome that you should expect. All right. Because remember, I treat people without the neuropathy that have balance issues and they're doing fine. So obviously, I want you to think about neuropathy. And when you're educating or doing the report of findings, you need to explain to them, look, if there's no communication between your feet and your head, how do you think you're going to be walking in the next few years? You've had this how many years? 5 years. So what do you think your balance is going to be like in another 5 years? You really need to take them down that journey, fear of worsening, right? Because I used to tell patients, look, neuropathy is not going to kill you, but it's going to handicap you one toe at a time because they're going to start
Wow.
cutting and they're going to start cutting. And guys, I've seen it all. I literally had a guy come to my office that had a black toe and he was playing with it. I go, sir, if you continue to play with that toe, it's going to come off. And it was going to come off. I felt I was like in Old Testament times. So it's just crazy.
Wow.
So
Right.
yeah, it was scary.
Any other tips or guidance or things that they should be, little tricks that they should be thinking about when these patients are in front of them? I think the one we mentioned, which is an important one, is when the patient's case is very severe, you throttle back in the treatment, right? And then you can increase as time goes on. Dr. Caleb seems to go to about 3 minutes, but I have heard that from a lot of our clinicians that if they're severe, they start gentle. They're like 90 seconds, 2 minutes, and they're like, hey, we're starting here. Is that correct?
Yes.
Okay.
Yes.
Any other
I,
tips for
and
everybody who's watching at home?
Yeah, so just an example of where things can run amok. I had a friend whose mom had neuropathy, and I told her, I go, I want you to do it 2 minutes. She did it 10 minutes each nerve. Now, was there any damage done? No, absolutely not. But the mom felt like her legs felt like tree trunks. And I said, okay, all you need to do is I showed her a little massaging mechanism for her legs and feet. It took 2 minutes, and then that sensation went away. So if there were ever any issues, obviously you call me or you call Freddy's or something like that. But just you got to listen to what we tell you to do. More is not better in this situation. I just want to make that very clear.
Okay,
Okay.
excellent. Thank you very much. Gentlemen, thank you very much for sharing your experience. And I'm sure that everybody who's listening home appreciates this as well. But if they want to ask you questions or learn more about you, Dr. Straw, will let you go first. Where do they find you?
You know what? As we're wrapping up, another thing that always comes up is, okay, it's one thing to become the expert of treating and having confidence like we're talking about today, but guys, the difference between a super successful office and an average office is great marketing. And so with neuropathy, this is why we were able to open the 7 offices, is because we have consistent marketing of how to get people, how to position you as an expert in your area. And we do this by doing lunch or dinner talks. And we have a proprietary way of reaching the people in your community with actual physical mail. And these people are old school patients. They still like opening, going to their mailbox. And so as much as everybody's trying to sell you internet marketing, which is great, we all need to do Facebook marketing. If you want to become the expert in your community with neuropathy, then you need to learn our marketing system, which is foundational, is basically using dinner talks. And we have everything, the full system from the mailings to the actual presentation. If you're willing to get in front of people or you have a staff member you can overnight become the expert in your community. And I just encourage you to, after you have confidence doing neuropathy, helping people with neuropathy, put in the marketing system. So whether it's doing the dinners or television marketing, and obviously Facebook marketing, you could blow up within 3 months. You could double or triple your practice with this type of all these systems aligned together, from having certainty in treatment to certainty in marketing and a consistent patient flow. Anyways, if you want to talk more about that, you can reach out to us at drbizboom.com, or you can call us directly at 866-740-1998. And with that, or you can scan the QR code that you're seeing right now on the screen. But with that, guys, get the system down in treatment and get a system in marketing, and you will change your life, your clinic life, your practice life. And then obviously, that's what we're trying to do, help more people. So anyways, it's been a lot of fun.
And
Thank you, Dr. Straw. Dr. Kalapp, where can people learn more about you or get your help as well?
just type in the Kalapp method. The Kalapp method, because I'm doing consulting, I'm really into, because back in the days doing neuropathy, we had to sell these packages, and Dr. Straw, if I'm wrong, I thought they were like $8,900 per case. And I'm telling you, our offices, and I'm not saying this to brag, that's not, but I was put in the fire a lot. So I had to perform. And I think the most I collected in a month, and I'm getting older, so I'm trying not to embellish, but I think it was 220,000 in a month. Part of me says maybe it was 175, but it doesn't matter. So with all that knowledge, obviously I got to share a lot of information with doctors. I want to learn how to do that. Now, I want to jump back to Dr. Straw. When Dr. Straw talks about dinner talks, and I want him to chime in, Dr. Straw, how many dinner talks do you think our offices did in Southern California in our heyday?
Well, we were up to 80 to 100 talks a month. So we had a system for that we had to figure out and nail down, because we got to the point where doctors weren't doing the talks. It was staff members. So that was a big revelation too, that you don't have to be the one doing the talk. But yeah, over 250,000 dinners. Um, we definitely fed the senior community, and we still do.
I would,
We're still
yeah.
doing.
And guys, it works. I have some of my clients that work with Dr. Bisboom, and they love, and I like doing the dinner talks because I was doing them, 10 years ago, and I was doing what, 3 or 4 a week for years. And my biggest issue was losing my voice. What'd you say, Doc?
I said people still want the interaction,
Yeah.
the human interaction. Everybody's trying to do everything on Facebook and Instagram only. It's like, if you put yourself out there, your clinic out there, and connect with your community, you will be the expert.
And you're fortunate, because nowadays we've kind of done all the hard work for you guys. Because Dr. Straw, what was it like getting people to a dinner talk back in the day with the LA Times? What did that cost on a Sunday? This will blow people's mind. How much was a full page ad in the LA Times back in the day?
It was like $12,000.
Exactly.
You're going way back in the newspaper, man. People used to read the newspaper. That was, and when that
Not
thing
anymore.
crashed, we had to come up with a different method. So direct mail still works.
Yeah, of course it does. It's very powerful. So back on what I'm doing is, definitely I'm here to help you. Anybody that has any technical issues with the Stimpod and want to know how to use it on their patients, because I'm still treating patients, I'm definitely here for that. But definitely I like consulting. I have many offices throughout the country and I'm looking more for like the smaller guy that wants to basically maximize his profits in a fair and ethical way. But it's all about communication. It's all about, how do you communicate to a Gen X, to a Gen Z, to a baby boomer? It's really different. How do you talk to different cultures? Guys, you're talking about money. Nobody wants to, what is it? What do they say? Everybody wants to buy, but nobody wants to be sold. So I have to teach a way of doing it without you being a salesman, because we're doctors. We're not salesmen. And you'll find it's not that difficult. So, and I love it. I think it's fun.
Some people are asking some questions about where do you treat the vagus nerve. There's a whole vagus nerve webinar, if you find it on the webinar page. People are asking about restless legs. Yes, we have seen good results with restless legs. Somebody was asking about burning mouth. Yes, we have seen good results with burning mouth. Maybe we'll get some other webinars on that. Thank you very much to both of you for sharing your expertise. To everybody still in the webinar, I want to let you know that